6 months, and you always tell me, you know, get on that flossing, and, you know, it seems like it's normal for my gums to bleed. You know, why is today different? Yeah, so when a patient says, yeah, but I've always been able to get my teeth clean, we always answer a patient when they are legitimately giving us a little pushback to say, you're right. You're right, Mary. We have talked about that bleeding before. You're right, Mary. We have discussed this before. But we now know through current research that this type of inflammation means so much more than what we thought even 6 months ago. And one of the things I love about working with Dr. Smith is Dr. Smith always tries to take a conservative approach first. And that's what we've been trying to do, Mary. But that conservative approach is no longer working. And that is a way that we can have a very, I'm going to use the term authentic conversation. It doesn't sound like we're trying to sell them into scaling your root planing, because that feels gross for all of us. It's not ethical. That's not how we, you know, that's just not our standard. But it's a very legitimate way for us to be able to discuss with the patient, you're right, we have talked about this in the past, but we now know. Guys, the patient doesn't need to know that we've known for 6 years about, you know, X, Y, and Z with oral and systemic and inflammation. And, you know, truly, we've decided that as a practice, we're going to draw a line in the sand today, and today we're moving forward. We're not going to hang out where we practiced 6 months ago, 6 years ago. We're going to move things forward. So thank you, Heather, for sharing that. So who wants to dish? What's the least satisfied? What are you least satisfied about your perio protocol or program right now? Come on, somebody. There must be something. It could be something small. Yes, sir.
It's almost non-existent.
Almost non-existent. Okay. So you are, thank you for being brave, because I bet there are about 19 other people that are sitting here thinking, I wanted to say the same thing. It takes a lot of courage to say that. So it's almost non-existent. So one of the things that can
He likes coffee a lot, by the way.
I'll see if I can pull out any kind of gift for you. I'll work something out for you. So when we say, you know, it's almost non-existent, you're not alone. So let's take a step back and let's talk about the, you know, epidemiology of it all. We were talking about public health and statistics beforehand, so y'all are going to love this conversation. But when you have patients and you're going to talk to your patient about perio, we run around and we talk about different percentages. What is your typical line when you talk to patients about perio and they say, oh my goodness, you know, I didn't know I had gum disease? And you say, well, you know, Bill, it's very common. X% of the U.S. population has some form of periodontal disease. Tell me your percentages that you're typically quoting to patients. There's no wrong answer, by the way. What do you typically say?
95%.
Sorry?
95.
95. So 95%. Okay, what? That's one number. What else?
35 to 40.
25 to 40?
35.
35 to 40. So 35 to 40%. Okay? So here's the thing. It's interesting, if you look at AAP or the ADA, or you look at the Centers for Disease Control and Prevention, everybody kind of has their own take on the numbers. So if we say the majority of patients, let's just say the majority of patients, and you look at those numbers, and they range from 40% up to 80% of the population. And then I want you to take a look at the percentage of patients in recare. Again, it goes back to running the numbers. Knowledge is power, and assuming things about your practice, it gets you in trouble. When you assume your overhead is this, that's probably not good enough. You have to know what your overhead is. So assuming that you think, well, probably about a third of our patients are in periotherapy or in maintenance, run the numbers so you know. So if you think about this, I'm going to ask the hygienist quickly. So for the hygienist, Heather, you guys are out of this conversation, so, you know, hold on, sister, I'll get back to you in a moment. For most of the hygienists in the room, what percentage of patients in recare would you say have at least early perio? So we're talking, it's a 4, it bleeds, but there's radiographic evidence of bone loss. Because just because it's a 4 doesn't mean it's a 4, it could be a pseudo pocket. So what if we said it's a 4 that bleeds with at least early loss of crestal bone? What percentage of patients that you see, hygienists in recare, fit that description? Don't be shy.
Close to all.
Okay, I heard almost all of them. That's a comment I hear a lot. Okay, well, let's just be super conservative. You know, what if it was half? What if it was half of the patients in recare? Think about that when you run your numbers. Doctors, how many of you see new patients first? Raise your hands, please. You see new patients first. Okay, so doctors, think about the new patients you saw this month. You're seeing what, 40, 50 new patients a month? Wait, help you with that, by the way. So let's say you're seeing 20 new patients a month. So doctors, what percentage of those new patients, I just described what we consider to be early perio, for, with, at least early loss of crustal bone visible on the radiographs and bleeding. What percentage of patients are you seeing as new patients that fit that bill? What would you say?
Most.
Most. So 80%, and I heard most. Okay, right. So here is a free online tool. Write this website down. This is a free online tool we offer to all of you. If you go to inspiredhygiene.com/perio-tool. All you have to do is have your office manager run your production by procedure report. Have them run it September 1st, 2012 through September 1st, 2013. And when he or she runs that for you, they're going to plug this number in. When you download it onto your computer, it's an Excel spreadsheet, so it's pretty easy peasy to plunk in the numbers. And when you put those numbers in, it's going to spit out what your perio percentage is. Because many times what will happen is you'll think, you know, we're doing a good number of scaling and root planing. So this is, for example, one of the offices that I've worked with, and they say, man, we did over 200 SRPs. Yeah, but then when you add in perio maintenance, and then you look at the numbers of patients that you see in prophy, it shakes out that you're doing 14%. Now, folks, we see practices where it's 1% or it's 2%. Not uncommon, but hey, you only have up to go from there. I mean, that's a way to really get the foundation laid. What you have to decide is, what's going to be appropriate for us for our goal. Again, like I said with Gretchen, if I said just go run, I mean, that's frustrating. Go run how long, and this is how much time it's going to take you to do that. I want you to do a mile in at least 9.5 minutes. So now she knows exactly what she needs to do. So please download that. It is free from us to you. It's a great resource. Share it with your team. Email me with questions that you have about that. And again, I'll put that slide back up at the end. You can kind of run up here with your smartphone and you can zap a picture of it, or I can email you the link directly. So here are 4 common, now there are many, but these are 4 common roadblocks that we see when we do an analysis of an office and their perio percentage is not where they want it to be. The 4 common roadblocks that we see are listed here. Number 1, not collecting enough data to make a diagnosis. So you have hygienists, I've seen this many times, you have hygienists that are so jammed on time because they're doing quasi-scaling and root planing on prophy patients. So they're so jammed on time, they're doing the best they can, so when push comes to shove, not everything fits in. So what they end up doing is spot probing. Or there's no protocol in place in the practice. So, doctors, you really, it behooves you to sit down and say, all right, on our recare patients, we're going to write it out. What's our standard of care going to be? Not talk about it. We're going to write it out as a team. Because if you talk about it, here's what's going to happen. 3 months later, you're going to walk in to do a hygiene check, and by golly, the perio chart's not done. And you're going to be fuming mad. Well, talking about it's one thing, but sitting down, using production time, and I know that's kind of using production time to say, all right, guys, let's map it out. What's our standard of care going to be? How often are we going to perio chart? On which patients? What data needs to be collected? Doctor, you might be fine with 6-point probing and bleeding sites. Great. Write it down, and everybody agrees to that. Or you might want more data collected. But you can't, as a doctor, make a diagnosis if you don't have all the data present. So that's one of the roadblocks we see to doctors feeling like, I know there's all this perio in my office, but it doesn't show up in the numbers. So having enough time to do that. Looking at how much time you give your hygienists. I will say this, that if you have less than 50 minutes, I've done this for 20 years, if you have 50 minutes or less, it is near impossible to collect the data, not only so that you, from a liability standpoint, are protected for documenting disease so you can make a clinical diagnosis, but it's also, it absolutely hinders and hamstrings your ability to have your hygienist be your co-diagnostician. Now I know in the Practice Act, hygienists aren't to diagnose, but I will tell you, in the most successful practices across the globe, when doctors have sat down with their team and said, let's look at x-rays, tell me about the bone, what do you see here? This is what I call a crown, this is why I don't call it a crown, look at this. Look how much of the cusp is involved. That's why when I come in, that's why I'm going to talk to the patient about a crown. No, we don't want our hygienist telling the patient they need a crown if you haven't calibrated them to that. That can really get the practice in trouble. So really making sure we're clear on what diagnostic information needs to be collected, critical. And if you have less than 50 minutes, it's really tough. And if you see your production doctors, you're not hitting your production goal every month, sometimes that's one of the reasons why. Number 2 is not being calibrated. On faculty, every year we go through clinical calibration. So we all sit down, we bring in these poor patients, and we all probe these patients so that all the faculty are calibrated. I do this when I go in and coach teams. We bring in a patient, and we sit down, and we all probe doctors too, because for you to see new patients, it's important for you to be calibrated. So we sit down and we work on things like technique, being able to read. I wear loops. I've worn loops for probably 6 years, and one of the things that I'll notice is when there's a lack of calibration, if the doctor says, man, I'm always getting deeper measurements than Sally, many times it's because Sally is of our age group where vision starts to become an issue, so wearing magnification. Real simple things like that, but getting calibrated on probing technique, getting calibrated on how you read radiographs, getting calibrated on all of the systems and diagnostic tools that you use, doctors, not so that your hygienist can be the mini-me dentist, it's so that he or she can help support you better, so that essentially when you walk into the room to do a hygiene check, I want you to envision the bobblehead doll that you get when you go to the base with your team. You essentially just confirm what the hygienist has pre-discussed with the patient. You'll have worked with a chairside assistant that's always 2 steps ahead of you, that's on it. Aren't they wonderful when you have that assistant that's always 2 steps ahead? Same thing when we talk about calibration this way. We discussed this a second ago, not having a written standard of care. And here's the thing, when we go in and coach teams, I don't say, this is what you're gonna do, and I map it out. We sit down and say, all right folks, let's get a big dry erase board and let's map it out. What do you want your standards of care to be? It is not up for me to tell you what to do. You have to decide in your practice what feels right. So Heather mentioned, that in their practice, their perio standard of care is, the 4 with the bleeding. And for some practices, they say, you know what, I want to be a little more conservative, so if that's what they want to do and they want to wait until it's a 5, it's not up for me to say, so it's up for you and your team. Here's the thing, if your team feels like they had a part in coming up with the protocol, they're much more likely to adhere to it. If they feel like you told them what to do and they had no voice in it, they are less inclined to have skin in the game. That's true with your kids. I mean, you might want your kids to have a curfew of, 10 p.m., but if you just say it's 10 p.m., sometimes they're not going to comply with that. If you sit down and say, all right, so let's talk about your curfew. Let's talk about what you think is reasonable. 9 times out of 10, they're going to come up with the same answer you wanted them to, but they're going to feel like a rock star because they're the ones that came up with the 10 p.m. So same kind of thing applies. Not holding each other accountable. So once you have those written standards of care, nothing derails the system faster than when doctor is not the leader and adheres to the protocol. So doctors, if you sit down and you map out, this is what we're going to do for perio, diagnosis and treatment planning. And you see a new patient on Monday, and the patient has a 5, and there's radiographic bone loss, and there's bleeding, and you say, well, I'm going to schedule you with Sheila so you can get your teeth clean. The hygienist is going to say, whoa, wait a minute. We just mapped this out. That's not a prophy, doc. That patient needed to be treatment planned for something other than. So really anything in the practice, it's a top-down leadership that really is, I can't stress it enough to you doctors, nothing makes a team work more succinctly, and nothing makes a team happier than when they have a strong doctor leader. And when I say strong, I don't mean, hard iron fist. I mean, all right, let's talk about it, let's decide what we're going to do, and you're the first one to lead that example. So if you guys are going to do morning huddle, and everybody says, yeah, we need to do morning huddle. And doctor says, all right, everybody's going to be here at 7:50 a.m. sharp. And so for the first 2 weeks, everybody's there at 7:50 a.m. sharp. And then a month later, doctor rolls in at 7:53. And then a month and a half later, doctor rolls in at 7:55. I will tell you what that does to team morale. It goes absolutely in the toilet. Because doctor leadership, again, I can't stress it enough to some of the younger doctors here, it's critical, absolutely critical. All right, so we talked a little bit about this. I will send you this slide, anybody that wants this, because it's kind of back to basics. And I teach at the dental school, and I know our dental students get all of about 2 weeks of here's Perio 101, and go for it. And then they start seeing patients in the dental school clinic. So I know how that goes. But getting calibrated as a team, especially when we talk about getting into the call area, I will send this to any of you. So getting really calibrated on how often we're going to probe, what data is going to be collected. Critical piece. Radiographic interpretation. Doctors, this is something that you are experts in. Sit down with your team and go through intraoral photos and go through x-rays. Teach your team how to think like a dentist, not so that they can be the dentist, so they can support you better, so that they can be there to assist you and tee it up. I mean, that's the key. When we see highly producing dentists, they have a hygiene team that tees it up for them so that when they come in, it's a much easier conversation with the patient. Risk assessment. You know, part of, Heather, what you guys probably do is you factor in risk assessment. You know, years ago, when a patient would tell me, and I remember this patient vividly in my head, he said to me, well, my daddy had pyorrhea. Remember that term? My daddy had pyorrhea, so that's probably why I have it. And I remember internally kind of rolling my eyes, not really, but it was kind of, you know, it has nothing to do with, you know, that your father had gum disease. Well, now I'm absolutely eating my words because, Heather, we now know that the genetic predisposition, that IL-1 polymorphism, we didn't know that stuff 10, 15, 20, 25 years ago. We now know this. So to be able to have those conversations with patients during health history. Health history just can't be any changes in your health history. Because the patient's thinking, you're already 10 minutes behind. I need to get back to work. And they're going to say, nope. They don't understand. So we coach on ways that you open-endedly ask the patient questions so that you can better risk profile the patient. Things like HbA1c, you know, doing periodontal therapy on a patient that has an A1C level that's 8 and above, you know, your outcomes, to set your expectations of what your outcomes are going to be, that needs to be factored in. And I'm sure our periodontist here, our perio guy that's in the room, our periodontist, will see that, you know, in your clinical experience, a well-controlled diabetic patient is a different ballgame than an uncontrolled diabetic patient. What's the number one complaint? I'm going to ask this open question here. You're all clinicians here, so what's your number one complaint about perio charting? Don't be shy.
Time.
Okay, time. Thank you. All right, let me show you something real quick. Y'all ready?
Start listening. 323. 212.
Can y'all hear?
222. Bleeding. 232. Jump to 3. Interrupted bleeding. Jump to 7. 215. Session 3. Jump to 3.
Come on up after, I'll show it to you. When you call out 4, it says boop, danger, and then when you call out, which is awesome, and then when he called out 7, it said warning, I think. So I think it's pretty great stuff. So that's the new Florida Probe VoiceWorks. I put it on your table so you guys can take a look at that. It's the new Florida Probe headless. It's really good technology. You don't even need a head. Headset, noise canceling. So if you work in open bay, saw this at CDA, and you know how, if you go to Yankee or you go to Greater New York and you're in the trade show floor, it is loud. It was spot on the money. Every time he said suppuration, the computer said pus, which, by the way, for the patient, that is awesome. Just sit here, who wants pus in their mouth? Nobody. So when you say suppuration, the computer automatically says pus. Oh, I'm sorry, you're eating. That's so rude of me. And when you get to the 4s, it'll say danger, and then when you get to, I think it's 6, it'll say warning, and there's little sirens that go off. It charts restorative. It charts everything. It is incredible. This software system is $2,425, and I'm raffling off one tonight. What? I am. So Florida Probe was very kind. I know. Heather is just absolutely. Heather's gonna beat me up in the parking lot if I don't give this to her. So that's one of the things we're gonna give away tonight. Please take the literature. It's pretty fascinating material. Take the literature so you can take a look at that. Incredible stuff, because the #1 complaint is periocharting takes so darn long, and doctor, for a new patient exam, that takes a tremendous amount of time during a comprehensive exam. So I'm going to give one away, and it is valued at $2,425. So on your blue raffle slip, I will take a little segue. All of you have a blue raffle slip at your table. Oh, look at everybody scrambling for their raffle tickets. How funny. You all have a raffle slip on your table. Dentsply implants, Philips Sonicare, Philips Zoom, Inspired Hygiene. We're giving away a self-study quick start guide that is $900, and we're giving away the Florida Probe VoiceWorks software, and they are going to do free training for you and for your team, and it's just, they've gone absolutely over and above. So make sure you fill out your blue slip. The blue slips that are on your table, some of you have already turned them into Karen, so hang on, I just want to make sure that all of you have that. So we're not going to do it right this second. Yes, okay, perfect. Thank you. We're going to do that in just a little bit. So I wanted to kind of bring you back and get your attention again. So really great technology. Come up and see me when we're done so you can sit next to me at the computer and you can hear it better. Really good information. All right, it wouldn't be a dental CE course unless we showed x-rays, right? It's kind of bright in here, but I'm gathering that you don't need it to be extremely dark to be able to look at this set of bite wings. And tell me what you see.
Bone loss, 30 months.
Okay, so I hear bone loss.
Rots and rots of bone loss.
Bifurcation. All right, so, you take a look at this patient, and you're I'm gathering that the descriptors you're giving me are the patient is not healthy per se. We have a patient that's periodontally involved. All right, so stop there. Now we're going to switch. Let's switch for a second. Now I'm going to show you a perio chart. Let's take a look at a perio chart. So if you look at this perio chart, now every software is different, so let me kind of orient you if you're not used to how this looks. So unless you have superhuman vision, nobody can see these numbers, so I will just tell you that the probing depths are here. If anything is 1, 2, or 3, it's in black font. This isn't Florida Probe. It's a different software. Anything that's 4 or greater is going to show up as red number, and then any of the bleeding sites for this software are going to be little red circles. So even though you can't see the numbers, I'm guessing you can see that very few numbers, if any, are greater than 4, and you see very few bleeding sites as evidenced by the lack of red dots on this patient's chart. So when you look at this, so doctor, this is a common scenario. You're walking into the hygiene operatory to do a hygiene check, and up on the screen is a perio chart. So the second your foot crosses the doorway, you can kind of already guess this is not an involved case. This is a relatively healthy patient. I'm not trying to put words in your mouth, but would you say that if you saw this, perio chart right when you walked in, you wouldn't think, oh boy, here comes scaling and root planing? Am I off base on that? Okay. Stop for a second, and I want you to take a look at this. That was the perio chart of the patient that we just saw their x-rays. So these were taken in September of 2011. This perio chart was done, I thought I used to have that date up there. The perio chart was done, I think, about 6 months, either before the x-rays or 6 months later. At any rate, does that make sense to you to see that x-ray and see that perio chart? Why do you think that happens? What are your thoughts?
Recession,
Okay, so I heard recession. Okay, could be.
fibrotic tissue.
What else? Okay. So in this case, this was a hygienist that had been practicing for close to 30 years. She's a really good clinician, but she was running a schedule that absolutely had her feeling underwater. So she had no time, so she was flying through perio chart. I sat outside of her operatory and I thought I was listening to an auctioneer. 1, 2, 2, 2, 2, 2, 2, 3, 2, 1, 2, 2, 1, 2, and I thought, my God, how does her assistant even keep up? She did have an assistant charting for her, which was unbelievable. So she was going through the motions of the perio chart because she knew the doctors would be upset if she didn't do it. But she just said, this is all I can do. I'm doing the best I can. I've got to get in there, and I've got to clean this patient's teeth, so I'm just going to get this perio chart done. And I'm not trying to criticize her, but there was absolutely no integration of what do the radiographs show and what am I seeing clinically when I'm probing this patient. The two should sort of make sense. In this case, again, because they were so jammed on time, the hygienist would take bite wings and would never look at them. That's what doctor's going to do. When doctor comes in, she's going to look at the x-rays. That's not our thing. Missed opportunity on many levels. You know, 2 sets of eyes are better than 1 set of eyes. So this is a good example, I think, of trying to do the best they can, but not having enough time to allow for that. So this is just a protocol that you can take a look at. It might fit with what your philosophy is for your practice, and maybe it doesn't. So before the class, I was talking to Gretchen a few minutes about the ADA codes, the CDT codes, and I said this book is sort of our Bible when we go in and work with teams. Anybody ever heard Dr. Charles Blair speak? Or yeah, it is absolutely critical for any practice. It has every code, soup to nuts, surgery, everything. And Dr. Blair has made it his life mission to study the codes, to understand how your admin team can better submit claims to get better reimbursement. He also has an online version. It's called practicebooster.com. Same Dr. Blair. I just happen to have the hard copy book with me because I just love packing my luggage full of heavy stuff. So I have this with me. Gretchen leafed through it. I'm going to pass this around if anybody wants to take a look at it. First hand up. No, you're not getting my copy. But first hand up, I'll pass it to you. It is an incredible, incredible resource because what's happened is you might have an insurance person in your practice that truly doesn't know what the codes are. Or you might have a hygienist that, the other doctor that she worked with before you bought the practice didn't understand the codes, and so to get really clear on what does 1110 mean and what does it not mean, really important. So I have this up here, anybody that wants to take a look at that. So this is a common protocol that we'll put in place is, we've got to set our parameters here. What are we going to consider health? What are we going to consider disease? And what do we treatment plan and diagnose the patient with if they fall outside of anything that's healthy? So this is just our framework. You'll come up with your team what makes sense for you and when you're going to start treatment and when you're going to refer. That's critical. What are we going to be able to handle in-house? Because I'll tell you, some of your hygienists might feel like, yeah, I can do an 8mm pocket, no problem. Some of your hygienists might say, you know what? If it gets to 6, I just feel like the patient's better served being referred out, and we have to just have that open conversation so that we can better serve the patient. Periodontist in the room, wouldn't you agree that if you had, the one thing that pains your heart most is that when you see patients that get referred to you, they were referred too early or too late? What would you say? When a patient gets referred to a periodontist, do you think periodontists say, ooh, great, they sent the patient to me at early perio? Or do you think they say, they sent this patient to me at the 11th hour and it's almost a hopeless case? What would you say? I see heads nodding. Yeah, absolutely. Most periodontists will tell you is that the patient was referred too late. So figure out what that's going to be and what works for your office. Not for me to tell you what that's going to be, but sit down and I'll be happy to help any of you write up your protocols. So let's switch gears for just a second. Let's talk a little bit about communication. So I know we have specialists in here that might not have a hygienist, but this piece of communication I think is critical for all of us when we're talking about interacting with our teams, or for the team members that are here, which by the way, I'm so glad there are so many team members here, when we communicate with our doctors. But for all of us as dental professionals, it really underscores to us the importance of not only what we say, but how we say it. So this is based on social science. So Dr. Albert Moravian did research, and it looked at oral communication. Now this is research from years and years ago. It was really the foundation of what we know about communication sciences. And what Dr. Moravian said is that when we look at oral communication, the listener will rely on the following cues to interpret what the speaker has said. And you all are speakers when you're in your operatory with your patient. Your financial coordinator is the speaker when he or she is in the consult room with your patient, the speaker. So it's all of us in this room. 55% of the impact is determined by the speaker's body language, postures, gestures, and eye contact. Whoa. Think about that. I have worked for 20 years with some doctors that can really break it down. They will go into really fantastic descriptions of how the CEREC gets milled. They'll go into really fantastic descriptions of bone regeneration, and it's great, and it's good information for the patient to have, but they do that communication while the patient is lying on their back like a bug on their back in a very vulnerable position. Have them go into the treatment room of this physician's office, and the doctor was to walk in and interact with the patient, and then the doctor was going to leave. Group B, the same thing. The patients were asked to please remove their watches. There were no clocks in the room. So here's what happened. In Group A, the physician would walk in, introduce him or herself to the patient, and the physician would stand during the interaction with the patient. You know, tell me what brings you in today. You know, tell me a little bit more about that and medications. And then at a set time, the physician wore, in this research study, they wore little beepers that would vibrate so they would know when their time was up, and then they would say, excuse me, I'll be right back, and they would walk out of the room. In Group B, they had 20 patients, no watches, no clocks. The physicians walked in, hi, how are you doing? What brings you in today? At the set time, they got the little buzzer. They said, excuse me, I'll be right back, and they would exit out of the room. So then the researchers questioned the two groups. So in Group A, where we had no watches, the physician was standing, the study subjects estimated that the physician spent 7 minutes with them in the treatment room. Interestingly, when you look at Group B, where the physician was seated, they estimated that the physician spent 14 minutes with them in the treatment room, when in actuality, the physician spent exactly 10 minutes on the nose with each study group. So what does that tell us? I'm going to ask you this question. So shout it out. What does that tell you about communication with your patients?
Perception is 100%.
Perception. Absolutely perception. So to coach some of your team members, or sometimes team members to coach our doctors to slow it down, and the knee-to-knee, eye-to-eye is hugely impactful, because a lot of times we get hung up with what we're saying, and in actuality, it's more of how we say it. So if you take a look, this is a strategy that we teach, especially when we're talking about perio co-diagnosis, is we always, especially if some of you, Doctor, you had mentioned, you know, there's a lot of perio that's, you know, left on the table in the office, and thank you for being so honest about that. So one of the pushbacks you'll get from the team is, oh my gosh, doctor, how do we talk to these patients about needing scaling or root planing? They've been coming to us for years and years and years. So you follow a sequence. Always, always. Every time with every patient, we always do it in this order. You pre-frame it. So, Mary, I'm going to be doing your periodontal examination like we always have, or your periodontal assessment, whatever term works for you. This is where we measure your bone support and we take a look at the health of your tissue. Mary, I want you to listen for numbers. Numbers between 1 and 3 are typically normal, and healthy gums don't bleed, period. Lay the patient back and start your perio assessment. Start your perio charting. Even if you have a computer keyboard next to you, always, always call out every number on every site of every tooth. Always call out bleeding. Don't say B. If you have an assistant that's doing the work for you and you say 2B, 3B, 4B, because if the patient continues to hear bleeding, 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 bleeding. And you already pre-framed it to say, listen for numbers. Between 1 and 3 are typically normal, and healthy gums don't bleed. And lean the patient back. Get started. 4, bleeding. 2, 3, 4, bleeding. The patient's eyebrows, now in the era of Botox, it's kind of hard. Patients' eyebrows don't look like they used to. But I will tell you is that what ends up happening is there's not this surprise at the end when you show them the perio chart, because you pre-framed it. Listen for numbers between 1 and 3 and healthy gums don't bleed. And you're going along. 2 bleeding, 3 bleeding, 4 bleeding. Guess what happens in the patient's mind? Heather, I know you can answer this. At this point, when you've called this all out, what are they actually doing in their own mind? They are self-diagnosing, absolutely. So the patient already kind of knows, ruh-roh, something's up. Now, if the patient says, oh my gosh, Stacy, wait a minute, you're saying 4, you're saying 5, what does that mean? We coach teams do not have a clinical conversation while the patient is still lying on their back. You say to the patient, you know, Jim, that's a really good question. In just a minute, I'm going to sit you up and we'll go over all of this. And keep moving. Because if you get into a big hoop-de-doo conversation about what the perio numbers mean and you're only a third of the way through perio charting, you've slowed the process down. Now you can't collect the data. Your doctor can't make a diagnosis. They can't make a treatment plan with you, so it's really a difficult scenario. So keep them moving. So once we finish the perio exam, you say, okay, let me give you a good rinse, let me sit you up. We coach that even if you have a beautiful flat screen monitor in your operatory, there's nothing like having a piece of paper that you can sit down next to your patient in a chair and you can say, you know what, let me go over this with you. And you can sit knee to knee, eye to eye with the patient with their printed perio chart to be able to explain to them, you know, you heard me calling out numbers. Do you remember what your deepest reading was? Yeah, you said 5. That allows the patient to be a part of their co-diagnosis. So that's a pre-diagnosis. So when we coach offices, we get the hygiene team very calibrated so that doctors feel very comfortable with their hygienist walking the patient far enough down the road. There are no surprises. They are highly calibrated. I can't stress that enough. That cannot happen if we don't have unbelievable calibration. And that doesn't happen just because you come to a CE course and you hear about it. It's putting systems in place and practicing it and having complete buy-in because it's the right thing to do for the patient and for the integrity of your practice to get those systems in place. And then you present the pre-treatment recommendations and then doctor comes in to confirm, hands in mouth, checking that patient so that he or she can confirm the diagnosis and can confirm the treatment plan recommendation. So that goes back to what I talked about as far as that communication. Yes, it's important to use words, but it's also clearly very important on how we communicate that. So these are the positions. So when we're going to explain what we're going to do, we sit in this position. When we're doing the perio charting, the patient's in a clinical position. And when we sit the patient up to discuss with them what the patient's perio chart looks like and the treatment plan recommendations, the patient's sitting back up. So remember, on the left picture, this is the ideal scenario for communication, but on the right picture, this is what your patient is used to. Give the patient an experience, not an appointment. Did y'all hear that? Give your patients an experience, not an appointment. They are used to being talked to like this with all the stuff on them. They aren't used to the experience where you're actually purposefully communicating that way. So, for the purposes of time, I want to have everyone go ahead and turn in your blue raffle slips so that we can wrap up, and we're going to do questions. Don't worry. Did you get a blue slip? Okay, in the back we need more blue slips. So they were at the front table when you came in. So let me get you the blue slips, no problem. Hey. So let's pass those back. Go ahead and get those filled out. Okay, so let's make sure y'all get some. You bet.
That's what I'm thinking. I know you.
All right. My email address is up here so that you feel like you can use us as a resource. So please come up. I know it's hard to see in the back. Come on up. I will be here. I'm not leaving until tomorrow morning. Not like here, but leaving the area until tomorrow morning. So I don't have any plans tonight. We can stay. We can chit chat. My email address is here. The website has great information for any of you that are just kind of trying to figure out ways that you can just tweak a few of the systems in your office. So please don't be a stranger and let me know how we can best support you. Anybody want to share one thing that you heard tonight that either was sort of an aha moment, or most of the time when I talk to a really brilliant group like this, it's not so much I teach you something new, it's sort of a reconfirmation of something that you do, that it was just nice to hear it from somebody else that I'm on the right track. So anybody want to share either an aha or sort of a, I'm going to recommit to this because now that she said it, that it reminds me. We used to do that and now we don't. Anybody want to share? Yes, sir.
I liked how you said when you're doing the perio charting, stating 4 millimeters bleed, and then go through 2, 3, whatever, and,
Yes.
and have the patients know in advance that bleeding is not good.
Yes. Thank you very much. Thank you. Yeah, so giving the patient a frame of reference. Otherwise, they just feel like they're a human pincushion, and we poke, 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 and they really don't know what it means. So to give them that framework. Thank you for sharing that. So